All right, so let's talk about GDDs, when and how. Are you hearing any echo?
But you are much clearer compared to earlier.
Okay. Thank you. So what I would share in the few minutes is to understand how GPDs have changed the way we manage the refractory glaucoma patients. Glaucoma drainage devices are essentially performed when conventional surgery fails or are at risk of failure. It is often used as a primary procedure in certain secondary glaucomas and in certain refractory glaucomas, and definitely after a failed previous filtering surgery. So we have two types of implants. One is the AGV, which is a valved implant. The other one is the RD, which is a non-valved implant. Among the valved implants, we have two models that are there, which is the adult and the pediatric one. And non-valved implants, we have an RD with a single surface area of 250 millimeters square, what is available in India. So it's very important to plan the surgery and the technique well ahead. And I think meticulous surgery and postoperative planning will go a long way in preventing serious complications associated with implants. So it's very important to choose the right type of implant, right size of the implant, place the implant in the location that is most ideal and possibly safer, and the positioning of the tube in the anterior chamber has also to be planned very meticulously to see whether it can be placed in the anterior chamber or in the centers or in the pars plana, and that long-term safety of tube-related complications can be prevented. While planning surgery, what precautions we need to take or what considerations we have? Always look at the size of the eyeball. Very small eye, for example, an ophthalmic eye, which is rare, but sometimes you have to end up doing an implant. Make sure that you're using a smaller size of the implant. If conjunctival is hard, then you have to plan it in such a way that location of the implant has to be placed in a location where the conjunctiva is scarred. Also, always post vitreoretinal surgery eyes, check for the buckle with a torchlight before you examine the patient on a slit lamp. So it's very important so that you choose the area where you don't have a buckle or an anterior buckle, and you will end up having a problem during surgery. Corneal clarity, presence of deep or shallow anterior chamber, excessive peripheral SNAK, all of these have to be taken into account before you choose the location of the implant. Of course, taking pseudo-taking or taking lens takers is very important to plan your tool. So the two types of implants that we have, the AGK as well as the RD, they differ in a very small technicality in that when you do a non-valved implant, because there is no resistance to the fluid drainage, we do ligate the tube, and nowadays we are also using an intraluminal stenting to prevent immediate hypotomy. And once the ligature opens up, usually the pressure continues by about 4 to 6 weeks. And with the intraluminal stenting, sometimes we don't want a sudden drop of pressure, especially in certain pediatric patients and certain difficult conditions. So we have a two-pronged approach of intraluminal stenting that is there that will possibly work at a later time point. So there are post-operatively, once we do a surgery, I think what is most important is to take care of them in the post-operative period. So post-operatively, we are worried about two essential things. One is the high pressure, the other one is the low pressure. So while high pressure is difficult to treat, believe me that low pressure is extremely difficult to treat. So hypotensive phase often occurs in patients with non-valved implants, and hypertensive phase often occurs with valved implants. But if we are not careful with the technique of the surgery, hypotensive phase can occur even with valved implants. So that's something that all of us have to be aware of. Blood fibrosis or high intraocular pressure following a valve device is a major problem that we have, and that's one of the reasons, although AGV is quite safe, in implanting, and the pressure reduction is also quite all right in the early postoperative period. Late bleb fibrosis and high intraocular pressure are a serious issues, because of which we tend more towards the non-valved implants nowadays. So what do you do when you have this valve implants? The first thing is you have to try and prevent this from forming. How do you prevent it? Early aqueous suppressants in the postoperative period go a long way in preventing severe bleb fibrosis and elevated hypertensive phase in these patients. So I typically start aqueous suppressants as early as sometimes even day 1 if the intraocular pressures are beyond 6 or 7. And that is helpful because the height of the hypertensive phase as well as the height of the elevated thick blebs that you have generally comes down with the early aqueous suppressants. Suppose it happens and then you have treated them medically, but you're not able to take care of it, or the pressures go too high. So like in a failing trap, I think it's also very important to know that if your bleb or the implant is failing, before you jump and do a second implant, we should try and see if we can salvage what is existing. So sometimes we also do bleb needling in these patients, but in my experience, bleb needling is like buying time. Over a period of time, they again go back to high pressures. Sometimes what we also do is we do something called as a bleb wall excision. So when we do a bleb wall excision, so we try and open up the conjunctiva, try and reach the thick bleb wall and try to excise the bleb wall and close the conjunctiva back. So this is one thing that we do, but in some situations even that does not help. And in situations like that, what we do, this is something that we've been doing for the past couple of years, is this is a specially designed blade that we have designed at LV Prasad. We also do something called as a valve leaflet destruction. So by doing that, so you do a bleb wall excision plus a valve leaflet destruction. By doing that, what we are trying to do is trying to convert a valved device into a non-valved device. And of course, we close the conjunctiva back. So this is about the high pressures. And post-operatively, we also deal with low pressure. So low pressures are even difficult to treat. And they typically happen either by 5 weeks when the ligature completely opens up, or sometimes even at later post-operative period when they develop severe hypotony and then related inflammation, choroidal detachment. These eyes can be really, really difficult to treat. And if you have seen 1 or 2 such patients, and after that, you will really be horrified in doing a non-valved implant. So all of these complications to a great extent can be prevented. How do we prevent hypotony? I think a meticulous insertion of the tube. So for me, it is always a 24 gauge needle that I use to insert the tube. I don't use a 23 as is recommended by the company. I use a 24 gauge needle. So peritubular leakage is something that is avoided. And apart from ligating the tube, I also do an intraluminal stenting with a ripcord. So that gives you a gradual reduction in intraocular pressure. To a great extent, hypotony can be prevented in these patients. Now, one may ask a question about what happens to the success of these implants. Have all of them been compared? So if you're looking at the Ahmed versus Bawel study and things like that, people have looked at 2 different devices. But if you go back and look at history of the Multino implant and all the other devices that you have, almost all of these implants have a success rate which is close to about 70 to 75% by about 1 to 2 years. And over a period of time, they do come down. And their long-term follow-up also has shown that over 15 years, their success rate was only about 25 to 26% with the AGV. So over a period of time, it's not that the tube gets blocked or the implant doesn't function, but the fibrosis that happens around the plate is a major problem. And that prevents the bleb from allowing the fluid to drain from in the anterior chamber into the subtenon space or subconjunctival space. So the ABC study also has looked at it. So if you ask me which is better, often the intraocular pressure control, like I just discussed, will almost be similar by about 1 to 2 years or 3 years time. But what is very important is that the serious complications related to hypotony are more common with non-valved implants compared to the valved implants. What has been our experience closer home? So Dr. Pandav et al. Have actually looked at the comparison of ADI versus AGV. And they have shown that the complete success rate, that means without the need for anti-glaucoma medications, was much better off in ADI compared to AGV. That is expected. What is also very important is the mean intraocular pressure by about 3 years was almost similar, and similar number of anti-glaucoma medications requirement was far less in the Adi group, but again, a slight preponderance of hypotony-related complications in the Adi group is something that is reported as well. How do they fare in children? Similarly, both the AGV and Adi do well, and without requirement for medications, or the high pressure phase or hypertensive phase is far less with Adi, whereas the hypotony and hypotony related problems are something that we have to deal with this implant. But nowadays, I can say that comfortably, even in high-risk patients, we are able to do a non-valved implant with the help of a so ligature plus the ripcord, so that you have a double safety, I would say, and then you have a gradual reduction in intraocular pressure. And I don't remove the ripcord before the 3rd or 4th month, depending upon how the patient's eyes behave. Sometimes I have a couple of children for whom the ripcord is still in the eye, but your pressure control is good just with the topical medications, and hence I don't have to go and remove the ripcord. So, which means that if this child without a ripcord would have actually ended up having a hypotony. So my contraindications to Adi, I think it's very important for each of us to say where you don't want to do a particular procedure, because like we say, it is very easy to say it is surgeon dependent and surgeon's choice, but how do the surgeon choose? So immediate reduction in intraocular pressure in a patient with uveitis, where you don't want any hypotony and hypotony related problems, very elderly people whose conjunctiva is very thin and tenons is almost always absent in them, patients with pseudoexfoliation, patients with neovascular glaucoma, especially post-transscleral cyclophotocoagulation, and in some one-eyed patients with a very small central island of vision. All of these patients do not tolerate hypotony. And of course, you want immediate reduction in intraocular pressure in certain situations. I would prefer an AGV. My contraindications to AGV are if one eye has had a very terrible hypertensive phase or a very high bleb, and these eyes have allergy to anti-glaucoma medications, because often post-AGV, although the pressure control is achieved, we do require 1 or 2 anti-glaucoma medications, or sometimes more, to control the intraocular pressure to a safe level. So if somebody is allergic to anti-glaucoma medications, I would rather not use a valved implant. And of course, children with aphakia and pseudophakia who have had high pressures for a long time, I would rather have a gradual and a slow reduction in intraocular pressure rather than a sudden flow and sudden decrease in intraocular pressure. So now we may want to ask this question. So there are 2 different devices that we have. One is safe, but it's not effective in the long term. The other one is not so safe, but it is effective in the long term. Do we have something that is in between? I think that is where the Paul glaucoma implant has definitely a role to play. So the PGI implant, although not available in India, we are doing it on a trial basis here, part of a multicentral trial. But I would definitely say that this implant actually has features which are the good features of both the devices. You don't have to ligate the tube. The size of the tube is much smaller, both the external diameter as well as the internal diameter. You just have to stent it with a 760 Prolene, and we don't ligate the tube. So there is immediate reduction in intraocular pressure. The tube is really small, so the contact to the cornea, or it is the proximity to the cornea also goes down. And there is also no high pressure phase, at least in the past 1.5 years that I've used these. I haven't had a single patient who had a hypertensive phase. So that way, I would say this is something that we need to really look forward to. So it has a low bleb profile, and IOP control is there right from day one. And people, at least for the group from Singapore, says that close to about 10 to 30% of the patients, they may require to remove the stent. But at least for me, as of now, I haven't required to remove the stent even in a single patient. And their pressures are maintained in the low teens to mid-teens. So to summarize, implants are a big boon in the management of refractory glaucomas. We have to choose them appropriately, know when to use, when not to use. And if you're using it, what is the right technique to use? And of course, following them up in the post-operative period to identify the complications and treating them appropriately goes a long way in safety of these devices in these patients. Thank you so much for your attention.
So that was excellent talk, a good overview of the 3 implants. The one on the horizon looks very promising. Thanks for giving a preview. Anybody wants to ask anything? So the bottom line is non-valve implants tend to give us lower pressures and similarly the hypertonic complications, and the valved ones tend to give us higher pressures and the hypertonic problems.
That was a very nice talk, Dr. Sirisha, as usual. Can you just elaborate more about the use of valves in children in general? Because you also showed us a paper that you published. So how differently would you approach glaucoma valve implantation in a child? When would you consider the pediatric AGV, and when would you put the adult-sized AGV itself? These are some things that you can throw light upon.
Yeah, thanks, Gauri. And I think it's a very important question. So there are two things that one needs to consider with regards to the pressure control with implants. So the first one is the surface area of the implant. The larger the surface area, the better the pressure control. So that's what all of us believe in. But we also have to see the size of the eye, the axial length of the eye, and how well is the conjunctiva mobile, and will that conjunctiva be able to take, and the eye, the size of the eye will be able to take the large sized implant or not. So often people say that they don't believe in using a pediatric implant because it's a small, they call it as baby Ahmed. The baby Ahmed doesn't work. I don't think that's true. In fact, I do use it even in adult patients. So to me, it is the conjunctiva. If the conjunctiva is really scarred and I have a buckle there and I have a scarred conjunctiva, but I have to do an implant because there's nothing else that we can do to this patient. I'm only seeing eye of a one-eyed patient, who is young with multiple surgeries. So this is the typical kind of patients that we deal with, right? So in situations like that, I don't hesitate using a smaller sized implant. Otherwise, axial length, for me, the axial length is cutoff is about 21 millimeters. So anything that is beyond 21 millimeters, I use a large sized implant, but any axial length that is smaller than that, obviously you use a smaller implant. And when do you choose a valve versus a non-valve? Like I said, whatever I had shown earlier. But what I have possibly changed my practice over a period of time is, earlier I would say that if I have to have a safe valve surgery, there's nothing, no surgery is safe, all of us know that. But if of the available ones, if I have to have a safe surgery, I would typically use a valved implant. But I can tell you that in my hands, despite all the precautions that we take, if I've had 2 or 3 suprachoroidal hemorrhages, it is with a valved implant and not with a non-valved implant. So I'm not saying one is better, the other one is, not better and things like that. But what is very important is, why does this happen? So to me, if somebody, let's say a child who's 7-year-old who's come to you, has had high pressures over the past 2 years, has been on and off medical treatment, or despite medical treatment, the pressures are not getting very well controlled, I would rather use a non-valved implant and make sure that I bring down the pressures very gradually and not use a valved implant where the fluid will start flowing immediately. So for the same reason why all of us are worried of doing a trabeculectomy and a phakic eye, that is because you don't want a sudden decrease in pressure and its related complications. So I would have the same contraindication to do an AGV as well. So where I don't have a control and day one and immediately, as soon as you put the tube in the eye, it will start filtering. So I don't want that to happen. In fact, maybe if I gave this lecture about 5 years ago, I would have said something different. So all of us learn, and I think we get wiser as we go by. So I today would use a non-valve device with an intraluminal stenting as well as ligation of the tube and with a couple of fenestrations to make sure that the gradual reduction in intraocular pressure occurs, and they seem to be quite safe. And I don't, like I said, I don't go and remove the ripcord before the 3rd month or 4th month. I will stretch myself until the pressures are under control. If it goes beyond control, even with oral medications, then of course, then I know that the bleb has become thick and I can afford to go and remove it, and they are generally okay. So that's the, my recommendation or my experience.
Yeah, I agree 100%. The single chamber aphakic eyes definitely are, nightmare eyes, and what you're saying makes 100% sense.